Now we go to ventricular septal defect. It is the most common cardiac malformation, accounting to 25% of CHD. It occurs in any portion of the ventricular septum, most common of which is your membranous type in the posterior inferior position anterior to the septal leaflet of the tricuspid valve. So your ventricular septal defect is a defect in your ventricular septum, and the shunting is usually left to right from the left ventricle, going to your right ventricle, going to your pulmonary arteries, and into the lungs for oxygenation, back to your pulmonary veins, going to left atrium, then left ventricle. For its pathophysiology, the magnitude of shunting is determined by the size of the defect and the level of your pulmonary vascular resistance. For small lesions less than 5 mm, the higher pressure in the left ventricle drives the shunt from left to right, and the size of the defect limits the magnitude of the shunting. In large defect more than 10 mm, the RV and LV pressures are equalized, so direction of shunting and the shunt magnitude are determined by the ratio of your pulmonary vascular resistance to systemic vascular resistance. For its clinical manifestation, in small VSD, usually asymptomatic with normal growth and development, only found a murmur during routine PE. Moderate to large VSD, there is delayed growth and development, dyspnea, feeding difficulties, decreased exercise intolerance, signs of congestive heart failure during infancy. On your physical examination in small VSD, the child is well developed, acyanotic with presence of murmur. Moderate to large size, there is poor weight gain, signs of heart failure, diaparesis, pallor, tachypnea, tachycardia, hepatomegaly, and crackles. For your inspection, small shunts, adynamic precordium with normal apex beat, large shunts with precordial bulbs and hyperactive precordium with apex beat displaced laterally. Palpation, you can have presence of trill in small shunts. In large shunts, there is parasternal lift with laterally displaced apical thrust and presence of systolic trill also. For your auscultation, in small shunts, there is loud, harsh, or blowing holosystolic murmur at the left parasternal border. In large shunts, less harsh murmur but more blowing at holosystolic murmur at the left parasternal border because of the absence of a significant pressure gradient across the defect. Your pulmonary component of which is your S2 may be increased due to a pulmonary arterial hypertension. There can be a mid-diastolic, low-pitch rumble at the apex due to increased blood flow across the mitral valve that indicates a QPQS more than 2:1, and this is your relative mitral stenosis. Diagnosis by electrocardiography will reveal small VSD. Can be normal. In moderate VSD, there is left atrial and left ventricular hypertrophy. In large VSD, there is left atrial enlargement and combined ventricular hypertrophy. Chest X-ray in small defect, it can be normal. And in large defect, there is cardiomegaly with varying degrees of left atrial, left ventricular, or biventricular enlargement and increase in pulmonary vascular markings and a prominent main pulmonary artery. In the presence of PVOD, there is already an enlarged MPA and hilar pulmonary arteries are prominent. Your heart is already normal with peripheral lung fields that are ischemic. Echocardiography will confirm the diagnosis, and cardiac catheterization is only done in presence of pulmonary vascular occlusive disease. In the presence of Eisenmenger syndrome, your pulmonary artery systolic and diastolic pressure will be elevated, but the degree of left to right shunting is minimal, and there is desaturated left ventricular blood. Management can be initially medical. You treat your congestive heart failure, you give your diuretics, digitalis, high caloric requirement formulas, correct anemia, and prophylaxis per your SBE. Non-surgical closure by umbrella device is usually now done surgery. Its timing is usually done in patients with significant left to right shunt wherein your QPQS is more than 2:1 after 1 year of age. Now we go to your patent ductus arteriosus. It is an abnormal communication or persistence of your communication between the aorta and pulmonary artery. The magnitude of shunt is determined by the resistance offered by the ductus, its diameter, length, and tortuosity in small PDA. And in large PDA, it is dependent on the level of your pulmonary vascular resistance. For its history, in small PDA, they are usually asymptomatic. In large PDA, there is signs of heart failure, growth retardation, and frequent respiratory tract infections. On your physical examination, small shunts will have the classical continuous murmur or your machinery murmur of the left upper sternal border with normal peripheral pulses. Large shunts will have tachycardia, apical diastolic rumble, bounding peripheral arterial pulses, and a wild pulse pressure. In the presence of PVOD, there will be accentuated P2 and there will be differential cyanosis. Diagnosis by ECG in small PDA is usually normal. In moderate PDA, there will be left atrial and left ventricular enlargement, and in large PDA, left atrial, left ventricular, or combined or biventricular enlargement. Your chest X-ray in small PDA will reveal normal size with normal pulmonary vascularity. Large PDA will have cardiomegaly, prominent pulmonary artery, and aorta with increased pulmonary vascular markings. In PVOD, there is already an enlarged MPA and Harler PAs. There will be ischemic lung fields and heart is usually normal. Treatment is by surgical or catheter closure. Small PDA is usually closed for the prevention of bacterial and arteritis. Large PDA closure is accomplished to prevent heart failure and pulmonary vascular occlusive disease. Approach in the diagnosis of acyanotic congenital heart disease, you have to determine if it is increased pulmonary blood flow or normal pulmonary blood flow. If it is increased in pulmonary blood flow with left ventricular enlargement or hypertrophy, think of VSD, PDA, AVSD. If it is on the right ventricular hypertrophy, think of ASD, PAPVR, and your Eisenmenger physiology. Maraming salamat po.